Thank you, Mr. Chairman. I'd like to thank the Academy for inviting me to speak at this topic here. So my interest in this area of natural cycle, IVF and IVM, started some 20 years ago when I was a much younger man. You can see me on the slide here, working with people like Zef Shoham and so on in England years ago, okay? And it was Bob Edwards who told me at that time, look, although we have to use a lot of medications to stimulate the ovaries, if we can find a way we can avoid all medications, it would be better. So because of this, we started this whole program of IVM, which we have done now for some over 20 years. So what I'd like to present to you today is some new data showing how its use, combined with natural cycle, may be considered as first-line therapy as an alternative to FSH and IUI. So the things I'll cover with you today are the clinical and lab procedure we use for IVM, because the IVF part we all know, how we can use it as an alternative to FSH, HMG, IUI, and some interesting information how we can improve our results by freezing all embryos and transferring them in a frozen cycle. So what's the definition? Now the classical natural cycle IVF, we all know, we give nothing, we collect the eggs when the follicle is about 17, 18 millimeters and we trigger. Simple, but we tend to get only one egg, and then the cancellation rate is very high because of premature ovulation. Because of this, most people would use a classical modified natural cycle where, again, you collect when the follicles are about 17, 18, but then you start antagonist when the follicle is about 14 mm, and you add a bit of FSH, HMG, and back therapy, typically for 2 or 3 days. But again, because the biggest follicle is already 17, 18 mm, you typically get 1 or 2 eggs, and you might get a pregnancy rate of 10, 15% or so. Mild IVF, we all know, the problem obviously with mild IVF is that no one defines exactly what is meant by mild. Some people tell me their dose is mild, but their dose which is mild is what other people use it as a routine treatment, okay? Now with early stimulation IVF, IVM, we can collect as little as 1, but we've collected as many as 125 eggs in one cycle. Some of them will be mature at the time of collection, some will not be mature. And the key role of IVM here is that because we can mature those eggs, we can collect them much earlier. And here, we typically give either no stimulation at all, or we give a very tiny dose, like FSH 150 or 75 IU on day 4, 6, and 8. And we trigger when the biggest follicle is 12 or 14 mm. Because it's less than 14 mm, there's no risk of premature ovulation. And you don't have to do much monitoring. We typically do only 1 ultrasound scan and no blood test at all. But because you trigger at that stage, you might get only 1 or 2 mature eggs. But you can get a lot of immature eggs yet, which are not yet undergone atresia. So, natural cycle IVF, typically 30% premature ovulation rate and a 10% pregnancy rate. Modified natural cycle, in the usual way, 1 mature egg, 15-20% pregnancy rate. And with the method we are describing here, we have reported, and other people have repeated it, even in new programs like in Turkey, a pregnancy rate as high as 35 to 50%. Now, so the way we do it is that if the patient has got no regular menstrual cycle, we induce a withdrawal bleed. We perform 1 ultrasound scan to see the number of follicles they have and make sure there's no big cyst or something. And we just do 1 ultrasound scan when we think the biggest follicle will be between 12 to 14 mm. And this is typically can be estimated based on their previous length of their normal menstrual cycle. And on that day, we give HCG 10,000 IU and then collect the eggs 38 hours later. Because we find that if we collect earlier, the number of mature eggs is a bit less. After 38, the results are not as good. And using this protocol, we've had no OHSS in over 10 years of treatment. In fact, now closer to 2,000 IVF cycles, 2,000 cycles. So here, typical picture of a polycystic ovary, measuring number of follicles. So I'll go through, for example, one typical case of how it is actually done. 25-year-old patient with polycystic ovaries, and she had developed severe OHSS in another center previously. So because of that, she was given 125 IU of Purigon, day 3 to day 5. Now her endometrium was noted to be very thin, only 4.7 mm, and therefore she was started on a bit of estrase. By 2 days later, she had 2 follicles that were 12 mm. But her estrogen now was obviously very high, 13,000 picomoles per liter, obviously because of the estrase that was given. Because the follicles had already reached 12 mm, she was given a trigger of busulfan 1000 IU, and the OP was done 38 hours later. And because the aim was to do a fresh transfer, she was given a bit of add-back ACG of 1500 IU on the day of egg collection. 10 mature and 17 GV oocytes were retrieved, and of these 17 GV oocytes, 13 matured after 24 hours. And 23 of the 23 oocytes were able to be fertilized, and therefore one 4-cell grade 2 embryo was transferred, resulting in live birth, and the other embryos were cultured to blastocyst stage, of which 4 were vitrified. 2 from the eggs that were mature on the day of collection, and 2 more from the eggs that were collected that were immature. Now, the egg collection method itself is just a modification of IVF collection, except that we tend to prefer to use IVF fentanyl and local anesthesia, but propofol is preferred if it's accessible. We used to use a 19-gauge single lumen needle by Cook, and good results are obtained, but my colleague, Dr. Steiner from Austria, has now produced the Steiner needle, which is a quasi-double lumen needle. You can look at it, the website there, ivfetflex.com. And the reason, the advantage of this needle is that with a single needle, it allows you to aspirate and to flush at the same time, even though the needle is only the gauge of a double lumen needle, a single lumen needle. A reduced aspiration pressure is used and multiple punctures are done. So the needle you can see here has been studied by US investigators in randomized controlled trials. And you can see the egg collection being performed here. So there's no difference between the egg collection for this and with IVF egg collections, except obviously the machine must be reasonably good. I mean, if you have a very bad machine, where the resolution is not clear, then obviously it's a bit more difficult. But most people will have a reasonably good machine, and therefore it's not that difficult. We have trained people for IVM egg collections for many years in Montreal, and typically someone who is skilled in doing IVF collections will need to observe 3 or 4, perform 3 or 4 under supervision, and off they go. So you can see here, comparing the Cook needle that we used before with the new Steiner needle, the number of eggs that were collected were a little bit higher, the pregnancy rate was significantly higher, the number of cases where there were blood clots leading to obstruction needle was much lower, and the number of needle punctures were much less as well, because you were able to flush without having to pull out the needle to go in again. And separately, we have looked at how IVM versus IVF egg collections are received by patients, and the complication rate in terms of ovarian bleeding, vaginal bleeding, fever, pain is the same between both groups of patients. And this is the patient, for example, that a colleague of mine, Dr. Dahan, performed using the same protocol as I showed you, polycystic ovaries, where he collected 125 eggs at the same sitting. So this is obviously far, far more than you ever need, but here is virtually with no drugs at all. So we strain the follicular fluid to identify the eggs, and once the eggs are seen, we have had a habit of doing ICSI. Although there's some data now suggesting that the sperm are perfectly normal, you may not even need to do ICSI. The eggs that are collected are cultured in media that was produced in my department years ago, although I must add here that frankly, whether you use medical or use our media by Cooper Surgical, the results seem to be the same. The M2 oocytes are ICSI'd the same day, and the embryos are transferred 2, 3, or 5 days after ICSI. If you do a fresh transfer, it's important you start estrase right after the egg collection and progesterone as soon as the day of fertilization. Although I will show you some data later on that we are moving now more to freezing all embryos for delayed transfer. Now, in a fresh transfer, the main problem is synchronization of the endometrium with the egg. And therefore, it's critical that the dose of estrogen we give is targeted depending on the thickness of the endometrium, as you've just heard about the thickness of the endometrium being important. So the endometrium thickness is fine, more than 8 millimeters, triple line, we'll just give estrase, 2 milligrams TID. If, on the other hand, it's very thin, less than 6 mm, we might give 2 milligrams TID per vaginum and 2 milligrams TID orally. Progesterone, in whatever form, is started after ICSI. Now, in our first attempts at IVM, we were quite lucky. This was almost coming to 18 years ago. In our first 25 series of patients, okay, we were quite lucky that we had 10 eggs collected. We had a very high maturation rate, and after transferring an average of 2.9 embryos with a 40% live birth rate. And I must say that we must always be acknowledging that sometimes in life things are due to luck. Because for the next 25 cases, we didn't have as good results anymore. And it was then after about another year and a half that we had good results. And I'm sure if our first 25 results had bombed, we may never have done it at all. But then, we were able to sustain these results for the following 10 years, so that I fast forward then from 1999, our first publication, to 2009, the year before Quebec covered IVF and then mandated that a single embryo transfer be done. So in the year 2009, we were able, in women under 35, to obtain a 55% pregnancy rate per cycle started, with an implantation rate of about 20%. There has been some concern that patients with IVM, their miscarriage rates could be a bit lower, could be a bit higher. So because of that, we analyzed it in different categories of patients. And we found that basically, if we exclude patients with polycystic ovarian syndrome, the miscarriage rates were basically the same. Because as we know, patients with PCOS do have a high miscarriage rates, and the majority of patients until that time for IVM were patients with PCOS. Now, we then did a mathematical calculation that what happens if you did repeated cycles of FSH IUI with about a 15 pregnancy rate per cycle for 6 cycles versus just offering modified natural cycle IVF IVM, which could be done every month. And we could see that whether or not you had good IVM results or bad IVM results, the results were still much better than with IUI. So the question then is the question of cost. There was also some question in the earlier days as to what would be the pregnancy outcome of a relatively new treatment at the time. So my colleagues, Dr. Bucket, looked at the babies that were born after IVM, compared them with IVF, and those who were conceived naturally and all given birth in the same hospital, being looked after by the same group of obstetricians. And this, I think, is an important way of comparison because we know that there's always been data in the past that when you look at statistics from different countries by different people who classify, even the way you classify congenital malformations and what is minor and major could be a little bit different. So we wanted to avoid this. And we basically found that the relative risk of congenital malformations, whether it was IVM, IVF, ICSI, were all about the same in comparison to spontaneous pregnancies in natural menstrual cycles. We also did some analysis to see whether or not the incidence of chromosomal abnormalities was higher, and we basically found that the incidence was the same whether it was IVF or IVM. Finally, we looked at the babies that were born after IVM, the final instance of congenital malformations, and we found that in 1,400 IVM babies born, from 1,200 pregnancies, the incidence of congenital malformation was 2%, in singletons, 1% in twins, which is about the same as spontaneous pregnancies. Finally, this is some interesting data from Australia, not our own. And what they did was they looked at IVM versus IVF. And they found that if you just look at the clinical pregnancy rate per fresh embryo transfer, IVM, the results were lower than with IVF, especially the live birth rate here. You can see here, 19% in their study compared to 31%. But if they froze the embryos and then compared the live birth rate per frozen embryo transfer cycle, in IVM versus IVF, it was the same. We have no exact explanation. I suspect the reason is because we still cannot we cannot synchronize the timing of the development of the endometrium with the timing of the development of the follicle. It's more difficult in IVF than in IVM than in IVF. So because of this and because of other data that we have heard at this meeting now, we think now that probably freezing the embryos and transferring in the frozen cycle is probably the way forward to go. So if you look at the comparison here, typically for FSH IUI, in most places, you'll be performing 3 or 4 ultrasound scans. You will start injections of FSH around day 3, 2 or 3 or 4, and you need about 7 to 10 injections of FSH. There's no egg collection, but there's an IUI, the procedure of which is similar to an embryo transfer. The pregnancy rate is about 15%, But because you allow 2 or 3 follicles to develop, the multiple pregnancy rate could be as high as 20 to 25%. Typically, in North America, the cost of the IUI plus drugs will cost about $2,000 or so. On the other hand, with IVM, the way I've described it to you, you did 2 ultrasound scans. The number of injections would be 1 if you do not give FSH, and you just give the ACG trigger, up to 4 if you give 3 injections of FSH and 1 injection of the ACG. There's 1 egg collection and 1 transfer, which is similar to the embryo transfer, to the IUI. But the pregnancy rate then is much higher, 30 to 50%. But the multiple pregnancy rate, because we put in only 1 embryo, at most 2 embryos, and we can keep the cost down to, in fact, now just under $4,000. So we tell the patients, you can do 3 or 4 IUI cycles, or you can do 1 natural cycle IVF IVM. And it's up to the patient to choose. Now, these data here are in direct interesting, okay? There was a paper published in the Australian Journal where they took patients who were developing 2 or 3 large follicles in response to ovarian stimulation. And then at that time, they randomly allocated them if they had mild male factor or idiopathic infertility to either IUI or IVF. And they found in these patients who were all about 33, 34 years of age, that the pregnancy rates of IVF were about 40% compared to IUI 12%. The live birth rate was 40% compared to 6%. And the cost per live birth was then estimated to be much lower in IVF than, in fact, in IUI, showing that, in fact, IVF may even be more cost-effective than IUI if you start it earlier. Another study looking at the cost-effectiveness of IVF versus stimulated or unstimulated IUI, I believe this was done in the UK, showed that with IVF, per live birth was about £12,600 sterling. Unstimulated IUI, unsuccessful, then moving on to IVF was about £13,000, and stimulated IUI, IVF, £15,000. So based on various different models, it does look that, in fact, it may be more cost-effective to be moving on earlier to IVF than to IUI. However, as we know, some patients are worried about taking too much medications, OHSS, blah, blah, blah. So because of this, in those patients, maybe the procedure I suggested, starting off with a modified natural cycle, IVF, IVM, might be more acceptable to them. If you tell them no blood test, just 1 ultrasound scan. Now, the question people always ask me over the years is, fine, you get good results in Montreal, but can it be repeated elsewhere? So I'm pleased to share with you here a relatively new center that was only 2 years old in Turkey that used our protocol in young women under the age of 30, okay? And they were doing IVM for the first time. So you can see here, these patients are probably different from many in other countries because they had a duration of infertility about 4 to 6 years, because Turkey in rural areas is like Israel and so on. Women start trying to have babies when they're much younger. At 19, 20 years old, they start having a baby. So by the time they're in their mid-20s and they're not pregnant, they will go for some form of treatment. So in these cases, some of them had had 1 or 2 IVF cycles already before, and then they went to IVM. They collected an average of 13 immature eggs. 6 of them matured, implantation rate of 34 to 47%. Okay? And they had a clinical pregnancy rate per cycle started of about 45%, and a live birth rate per cycle started of about 35%. So here is clear evidence that if it can be done in a relatively new center, with just by 1 visit from someone from my group, okay, it can be done basically anywhere. So the results are repeatable. And more recently, the same group has done some studies now looking at, instead of using some drugs as we do, because they want to lower the cost of drugs even more, they use only a little bit of FSH, 1 injection, but add some Fumara, letrozole instead. And again, you can see that the live birth rate is 40% with letrozole priming to cut the cost down. So in conclusion, IVM makes treatment simpler, reduces the cost, and eliminates OHSS, which is different from even antagonist protocols with agonist trigger. I mean, we all now have moved to antagonist protocols with agonist trigger. But we also know that even with that protocol, either with a freeze-all strategy and so on, there will still be occasionally, albeit much less, chance of OHSS. And the only way you can avoid OHSS completely in the high-risk patients is that if you do not stimulate ovaries at all. If you give one injection of ACG, the advantage you get a bit more mature eggs, and you can make the eggs mature faster. So you can select out which are the best quality embryos to then select for transfer. Especially nowadays that when we are moving to single embryo transfer, right? And so if you get lots and lots of eggs, the question, and lots and lots of embryos, the question is that short of doing PGS for all of them, how do you know which is the best embryo to transfer? So those that mature earlier will give you better quality embryos. And in young women at least, you can get quite good pregnancy rates, okay? And using this same protocol, we've maintained decent results now for more than 10 years. But what is more important, I think, in the last few years is these two developments. The first is that the realization that we were probably wrong to advocate always doing a fresh transfer before, but now with a frozen transfer, we may be able to get results which are finally comparable to IVF. Now, the indications of IVM, therefore, I think, evolved now away from preventing OHSS, which is what we started off by doing IVM to prevent OHSS, but I think it's still a relevant treatment nowadays because there are other patients for which it might be useful. Sometimes, in patients, for example, with cancer, or other medical conditions where there's no time or contraindication for stimulation of ovaries, we can perform IVM, collect the eggs, and preserve the fertility. Okay? And we can do it as short as a period of 3 or 4 days from the first seeing the patient. But it can also be a first-line approach in other women who are young, who may prefer to do this rather than going to IVF straight away, because the pregnancy rates are still much better than IUI. But the most important information I think I've showed you today is that these results can be obtained even in new centers trying it for the first time. Thank you.